All right, and then advanced slides. So before we start, I'd quickly like to introduce our newest member of the SHIP TA team, Matt Bancroft. So Matt joined our team as a program specialist in February. Matt was raised and currently lives in Arkansas, and he's previously worked in and lived in the DC metro area, Tampa Bay, West Texas. And he has over 6 years of healthcare industry experience, including time spent as a behavioral health provider in rural school districts. Yeah, so welcome, Matt. I'll actually turn things over to him to get us started with our topic for today.
Good afternoon, everyone. Thanks for the warm welcomes. As Andy said, am kind of new to the center and will be your host MC for today. So don't judge me too harshly. Other than that, I hope you guys learn a lot and pick up on some new information. That's why we're here today. If you have been on any of these conferences, you know sometimes I change my background to something funny. Today, I'm going to be serious with it. I have a pretty neutral background. But if you ever cross paths with me in the future and I have a magic school bus or a llama background, it's just me trying to infuse some lighthearted nature into these Zoom calls. So today we have the setup is kind of 3 different groups set up in about 15-minute segments. We're going to talk about individual investments by hospitals, with Lisa from Kentucky, telehealth starter kits with Cassie and Jenny, and then tele antimicrobial stewardship programs with Rebecca and Lindy. And if it's and before we get started, I think Soleil is here. Hi. And she would like to say a few things, and then after she says what she needs to say, then we will get started.
Hello, everybody. I am so excited to join in just briefly for today, but as all of you know, I will be going on a detail, and wanted to just take the time to just say I love my SHIP grantees and just really appreciate the work that you guys do. And this is by no means me saying goodbye, but at the very least, thought I should show my face on today's session. But that being said, really looking forward to this session. And Janine will be still a part of the program and will definitely be available to you guys. It's a slower time for SHIP in terms of the big things, but before I leave, I'm going to make sure I do some updates with calendars and have those ready. And yes, your NCCs have been approved, and spoiler, more money. With that being said, thanks everybody and enjoy.
Hey, thank you, Soleil. Hey, for those of you, your audio was kind of cutting out a little bit. But if you didn't catch all of that, she is going to be working with a different department for the next few months, so she won't be around as much. But again, to narrow it down, she wishes all of us well, is there to help where she can, and will miss us in the meantime. Did I get that correct? Okay, perfect. So I just kind of narrow it down. So again, thank you for being here. Lisa is up next. And let's see here. Lisa is the Rural Health Manager and SHIP Coordinator at the Kentucky Office of Rural Health, and she's going to be discussing individual investments by hospitals in Kentucky. Lisa, thank you for joining us today, and I will let you take it from here.
Thank you for having me, Matt, and thank you, Sally, for inviting the Kentucky input in on this situation. I see my other co-presenters have taken kind of a buddy approach, and I'm questioning why I didn't do that myself. I am still relatively new to the office. This is just past my 2nd year and even a little bit less time with the SHIP program. So I have learned quite a lot in the past 18 months or so, and still have quite a lot to learn, but it's been interesting along the way, and hopefully I can help add some input to the world of telehealth. So Andy, if you could go to the next slide. Okay, so it shouldn't be that hard to seek medical help, but we know it's not always that easy. In Kentucky, we've got 84 counties, which is about 70%, designated as rural health professional shortage and or medically underserved areas. Of those, only approximately half have a SHIP hospital located within the county. So like all rural areas, transportation, is one of the challenges. We're, aware of these challenges. They are rural patients face while attempting to access their health care, lack of access to specialists, transportation. Basically, we know that it is more difficult to be sick in rural areas. Andy? So, begs the question, what are we doing about it? So, if we know that there are barriers in getting patients into the doors or connected with the appropriate professional, then what is being done about it? To address these issues here in Kentucky, we have 30% of our SHIP hospitals have utilized their funding to implement or expand their telehealth services in recent years. Due to the COVID-19 pandemic, these services have proven to be even more invaluable, resulting in 35% of our hospitals projected to utilize SHIP dollars for telehealth services starting the next funding year. So we do see some growth in that area. Andy? So how do you start? In order to build and maintain a strong telehealth program, you must develop a business plan for telehealth services. So basically, you need to look at what kind of services are going to be performed. What are the process or procedures? Basically, how's it going to work? How's it going to look? You got to secure the proper licensure and privileging. And of course, there's the financial aspect. You got to work out your billing, your coding, reimbursement to get compensated for those services provided. And, telehealth rises and falls on technology. And as we know in rural areas, that's sometimes a challenge, with appropriate bandwidth, adequate bandwidth, so that's something to consider. Also, do you have service agreements in place to ensure that those services are continual? And then you also must observe and maintain your health analytics. So this is a good way to identify, the gaps in care. How's it working out? What areas could be improved upon? Are you integrating with your medical records department? Are those best practices being developed for your particular situation? And of course, staff needs to be identified and trained. And finally, you must remain up to date on practice standards and guidelines. Because telehealth is technology driven. We all know technology changes rather quickly. So, you must stay on top of, the next platform or technological aspect to make the whole system run. And I apologize if I'm going a little quickly. Andy? Okay, so how is it used? As our hospitals' telehealth programs grow, they're discovering exciting and innovative ways in which to expand the services with the technology. So in Kentucky, we've seen some uses with mobile mental behavioral health units, assessments, things such as that. While it's not something that we see very often here in our state, but it has been used to help with translation services. That way patients who do not have English as their first language, we can ensure that they do know, what's going on with them medically, that they've got all the information provided in a way that is natural to them to understand. Used for outpatient wound clinics, that way you can keep an assessment with those, occupational health, inpatient visits with specialists. This is probably one of the biggies that we see quite a lot. We partner with neurologists, orthopedics, just the whole gambit of specialists that otherwise our rural patients may not necessarily have easy access to, either because of transportation, because of time, there's all those factors involved. And of course, there's specialty clinics as well. So there's really no wrong way to use telehealth, is kind of what I'm learning along the way. Next slide, please. So we're doing all this, and is it making a difference? Hospitals have reported increased patient satisfaction and confidence in their quality of care. So yeah, we do think it is making a difference. It lets our patients in rural areas know that although it may be a small hospital in the middle of nowhere, it is utilizing some of the same technology that they have heard so much about over the past year. It helps to let them know that they are not being left behind the times and that they can actually be treated by the same specialist from one of the metropolitan hospitals. So, we see that it reduces stress and fatigue on the patient with transfers and different follow-up appointments, things such as that. It prevents that delay in their diagnosis or their treatment. Communication, safety, quality of care, all that's been enhanced. And especially for those physicians that aren't on site, it gives those physicians the opportunity to follow up with their patients, in a different way. And we actually see them also expanding their partnership with local schools. So our students are getting easier access to the healthcare that they often need to. In doing this presentation, I sent out kind of a little flyer to all of my hospitals that have used SHIP for telehealth in the past. And, that's where I gleaned this information. And, there's a couple little quotes. One of them was, we've been able to reduce transporting our patients outside the facility, saving them the inconvenience of traveling nearly an hour by an ambulance in most cases to and from these appointments. So if you're already sick and feeling bad, that, hour back and forth ambulance ride is not, going to help you feel any better anytime soon, for sure. Next. So how can we improve upon telehealth in our hospitals? So that was another question that I asked them, what can we do as a SHIP program to help improve upon, the telehealth services that you already have in place or help you expand, and they asked for platforms and best practices to enhance it. Like I said, those are ever changing, with the advent of new technologies and faster, things. And another said it would be good to continue information on billing for these services and assisting with grants for updating and adding telemedicine equipment for rural facilities. And one thing that really stood out for me was this last one, as 1 in every 4 patient visits is anticipated to be virtual going forward. 1 in every 4 patients they foresee being telehealth going forward. That just, really stuck out to me. So the continuation of funding support to expand these programs will be crucial. And one of the questions I asked was, if it were not for SHIP, would you be able to have the capacity? Would you be able to offer telehealth in your hospitals? And the majority of them said, probably, but not in, in a much more limited capacity. So, this allowable investment for these dollars is making a difference in that side. And, hospitals, we are independent with our SHIP program. Our hospitals decide, what they do upon their self, with some guidance and, any questions they might have. So it's a little bit different. Each hospital might use it a little different and transfer it, to fit their needs. All right, next. So I don't think I quite used up all my time. It seemed much longer when I was making it than it did in real life, I suppose. But once again, my name is Lisa Garza. I am the Kentucky SHIP coordinator. Here's some contact information. And if you have any additional questions or anything, please never hesitate to reach out to ask me. Thank you so much, Andy and Matt.
Thank you, Lisa. You didn't use up all your time. That's awesome. And it's always quicker. You always think it's going to go longer. Does anyone have any quick questions for Lisa, just about some of the information that she might have presented? I'm also going
Hi, it's Lynette.
Oh, go ahead, Lynette. Sorry.
Hi, Matthew. I just had a quick question for Lisa. Did you happen to utilize the Northwest Regional Telehealth Resource Center for any of your telehealth toolkits or services? Because I recently completed that training through TASK, through the National Rural Health Resource Center, and it was a phenomenal tutorial on telehealth. I was just wondering if you utilized them at all and if you were familiar with them.
Actually, I do not believe I am familiar with it. I've got my pen and paper right now. That you said that was the Northwest what?
It is the Northwest Regional Telehealth Resource Center, and TASK did a training on this. I think it was February 24th or the 25th.
Okay.
I don't remember the exact date, but I did the tutorial and it was so beneficial for me because I'm a nurse practitioner, and I just think it really provides a thorough overview of how to utilize telehealth and everything. It was the nuts and bolts of telehealth. So that might be another resource for your hospitals to utilize this so that they could, you know, it covered everything. I mean, it covered stuff that
I'm sorry, I do believe I was on that same call. I'm one of those people that I really am really bad with names, so I apologize in advance. But it didn't ring a bell at first, but once you started speaking, I do believe I participated in that, and you're correct, it was very beneficial.
Okay, great. Yeah, the training that I did was you know, it was like a 6-hour training, but it was very helpful for me personally. I'm gonna offer it to my ship.
Great.
Thank you so
Lynette.
much for sharing.
Yeah, no, that's awesome. I will see what we can find, see if we have any material we can share in the chat as well. I'm also going to put Lisa's contact information because that slide's about to disappear. And I just posted it in the chat as well if you want to mark that down or copy it down. If you have any other questions or anything like that, you might want to address to her or pick her brain about something, I'm sure she'd be more than happy to assist with that. Lisa, as always, thank you so much. I appreciate you. Oh, Sally just posted a Telehealth 101 link in the chat box. And so there you go. Thank you, Lisa. And so we are going to get to our next presentation, which is with Cassie Kennedy. Cassie is the SHIP and Flex coordinator at the Iowa Office of Rural Health. And is it Jenny? It is Jenny, right?
That's right.
Okay, good. Jenny Price, who is the grant director at Hometown Health, and they are going to talk a little bit about telehealth starter kits in Iowa. So again, if you got a question or anything like that, keep that in mind. We'll open it up at the end of that. But right now, Cassie and Jenny, it is your time to shine.
Thank you. I'm going to start off and then I'll hand it off to Jenny. So you can go on to the next slide here. Just a little bit about Iowa's SHIP structure. I think it's a little bit unique. Iowa has about 90 SHIP eligible hospitals. So because we have so many hospitals, we actually subcontract the work out, so we don't have to have individual hospital contracts. So we go through a competitive application process, an RFP process, and with that, Hometown Health is our subcontractor for services. And then within that, hospitals can either choose to go the consortium route or a direct award route, which I think Jenny will talk about more. You can go on to the next slide. And just a little bit about IDPH. We're located in Des Moines. We're part of the IDPH Rural Health Team, which is part of our Bureau of Policy and Workforce Services. And along with me, there are 2 other sort of program coordinators who oversee grants and contracts. And then we have 3 support staff. So our office includes the State Office of Rural Health, Primary Care Office, Flex SHIP. We also do the HRSA designations, J1 waivers, and then we have a lot of other state funded contracts too. You can go on to the next slide. So with that, I'll introduce Jenny Price. She is the lead for Hometown Health in the Iowa SHIP program. And Jenny is the Director of Business Development. She joined Hometown Health in May 2014, and she has healthcare risk management and marketing experience, but Jenny is just an all-around expert. I feel like she knows a lot about everything. She's amazing to work with. She's a great program planner, great program manager, and it's just a pleasure to work with her. She holds a bachelor's degree from Berry College in Rome, Georgia in communication and a Bachelor of Arts degree in religious studies. And then she has a variety of designations too, as you can see there, but really I can't say enough about Jenny's ability just to come up with great ideas for our SHIP program. So with that, I will hand it over to Jenny.
Thank you, Cassie. Thanks everyone for giving us a chance to share a little bit about what we've been doing in Iowa for telehealth the last few years, and our 2019-2020 program, like probably most of you, threw a couple of curveballs to us. So thank you, Dawn. So we kind of had to do some adjusting last minute when COVID happened to help our hospitals. And so that's what we're going to talk about a little bit today, is kind of what we've done traditionally for telehealth, and then last year how we kind of had to change directions and try and help our hospitals. So Hometown is an organization. We started in the Southeast, and HCHU is our education department. We've got an LMS, and it's really just focused on rural hospitals and rural healthcare. That's who we work to support. And this is our 6th year working in Iowa, and we also have the pleasure of working with Georgia, with Dawn in Georgia, as well as some Florida hospitals. So for last year's program, which is what I'm going to talk about, just a little bit of a case study of what happened last year. We have 79 hospitals that were SHIP eligible and participated last year, and 70 of those opted to be in the consortium. And so we did work with 9 of them to do some sort of direct award of funds, and many of those direct awards also focused on telehealth. So it is a big focus in the state, but we're going to be talking about what we did with the consortium hospitals. So Cassie mentioned this, our role is really to provide management and oversight of the program. And for us, that means going out and coordinating group purchases of all the goods and services based on what's selected by our consortium hospitals on their application. That's how our budget's determined, and that's really where we look to focus our activities. And a lot of that has to do with coordinating all of the other groups within the network, within the state at a national level, and developing those contract processes to bring a whole lot of value to those 70 hospitals. So the consortium is really made up of our hometown team. There's only 18 of us, and we've always worked remotely, and we travel around to our hospitals a lot, as well as our Iowa SHIP hospitals. We've got several state and regional networks and stakeholders that we work with, Iowa Healthcare Collaborative through Flex, and the AHAM chapter in the state, as well as some of the others that I'm going to talk about regards to telehealth and NOSOR and a whole bunch of organizations. Then we have our business partners who are committed through MOUs to serving the hospitals through the consortium. We've got about 35 organizations, and they're really key to what we're going to talk about today. And so I wanted to mention those, as well as a whole bunch of trainers and subject matter experts as well who have agreed to participate in the consortium through MOUs. So just to give you a quick picture of what was going on. So our consortium hospitals, if you manage a consortium in your state as well, you know this, pool their funds. And we do a whole lot of training, very training and education focused based on the SHIP menu, of course. We do a lot of workshops and conferences with them, as well as a whole lot of webinars throughout the year, about 300 or so. But every hospital within the consortium also gets to select a project option. And these are pre-negotiated discounted services or pre-approved use of funds, for example, for their HCAP vendor or telehealth equipment. So when March rolled around of 2020, we had a tech and telemedicine conference planned to do live in Iowa. And then, of course, when COVID was going on, we made the decision not to hold that live. We held it virtually, but what that did was quickly freed up some funds to figure out in the last month or two how to utilize to continue to meet their needs in tech and telemedicine. And so it was kind of a rapid process there of coming up with a solution. It was a good problem to have. It meant we could provide some more resources for them, but of course, not a lot of time. So we had to quickly determine what are the remaining or new needs of hospitals in this category, of course, what's allowable under the SHIP menu, and how could we distribute it. It turned out to be about $23,000 in funds evenly, or at least offer it equally to the 70 consortium hospitals and quickly and efficiently in 1 month's time. So we worked with IDPH to come up with a solution. You can go to the next slide. And decided to offer an additional kind of second project selection for that last month or so. So during that month of April, we really relied on those consortium partners that I talked about. We said, hey, here's an opportunity to serve our hospitals. Here are some of the needs that haven't been addressed yet. What can we do to meet their needs under the SHIP menu areas? And our partners really came through. And we were able to come up with 4 different options to offer to them. If you recall, at that time, a lot of telemedicine equipment was out of stock at that time. Things that our hospitals were needing, everybody was needing at that time to get set up. And so our partners were really able to help us in that. Things that we had already offered, and I wanted to share this because this is pretty traditional from year to year, some of the resources that we really build up kind of in their library of resources for this menu item. As I mentioned, we had that tech and telemedicine conference virtually where their regional telehealth resource center, which is GP Track, contributed to that, as well as a lot of our trainers. Our hospitals have access to a subscription on hthu.net's School of HIT and Transformation. There's dozens and dozens of support courses related to telehealth. We also work with the National School of Applied Telehealth, and they've got a series of certifications that came out of CTREC, which is the Southeastern Telehealth Resource Center and Global Partnership for Telehealth, where they've got some certifications for telehealth presenters and telehealth program managers, different certification programs online. As I mentioned, that many of the hospitals had the option to select that as their primary project already for the year. So we work with the hospitals there. And then we have also worked with their regional resource center, which is GP Track. They offer a discounted registration for their regional conference as well. So those are some of the things traditionally that we've done in the area. But when we had these funds to spend fairly quickly, these are some of the other things that we came up with to offer to them. So I'm not going to go over these. You've got them in the slides. By the end of the month, we came up with 4 options that were feasible for that last month, which I'm sure it's probably a very busy month in May for you all as well. You understand what that's like. Our hospitals got just an information sheet on the 4 different options. And then on the next slide, we collected their responses through an online survey, which we use fairly often with our hospitals when there's that many hospitals and we need to get responses. They're very used to submitting surveys back for us. And then also did remind them there that this is to be used, it's not general equipment purchases aren't allowable. This is that they had an intent to use this either for their telehealth program now or for the development of their program. So then next, I'm not going to go through in a whole lot of detail, but these were the 4 options. The first one was a getting started bundle. And this is what Global Partnership for Telehealth was able to source for us and get some discounted pricing. This is what they had recommended and they were seeing other hospitals purchase. Global Partnership for Telehealth also came out of a regional telehealth resource center. So we work with those pretty often. And we're able to get us some group discounting and very fast turnaround on some of the equipment to get physicians set up to be able to continue to serve their community with what was going on. Option B was a peripheral, also in partnership with Global Partnership for Telehealth, that they were able to get out a Littman stethoscope. Option C was with All Health Choice to get a platform set up for hospitals who did not have a platform already. That was to cover their setup fee. And then option D, for those who did not need equipment, we were able to offer some additional training in partnership with Star Telehealth. They're out of Virginia. And we had worked with them before to do some telemental health training. We had a lot, as I mentioned, a lot of other training already. So we were looking for something new that they didn't already have access to. So I believe on the next slide, you can kind of see the results of how those 70 hospitals made their decision. Most of them selected that option A, or 56% of them, that getting started bundle. They just needed the equipment to get their physicians up and running and being able to offer telehealth. And then you can see the patient presenter equipment, the peripheral there, and then nobody selected the platform, the startup fee for that platform, which was interesting. Of course, it's very telling what the needs of the hospitals are from these selections. And a handful did select the telemental health training. So just really to close out some lessons that we learned through this, and I think probably a lot of us have been through very similar in the last year or so, just not waiting to establish some of those collaborative partners. You know, we've been working on this particular consortium for 6 years now, and really finding those partners who are committed to rural, committed to these hospitals, and can really jump in to help when we have something like this come up. I learned personally, we always need to have a plan B for those big budget major items that are in the plan for the year, and something in mind. We definitely do that now when it comes to like a workshop or a conference, for example. And then the other thing that was sort of a surprise is as I mentioned, we do a lot of those surveys for our hospitals to collect that information and get documentation back. And we usually give them, okay, let's try and give them a month, or let's try and give them 6 weeks to respond to this. We didn't have that in this case, and we gave them a week, and all but one hospital submitted by the deadline. And so we thought, okay, maybe sometimes giving them a shorter window where they maybe don't get distracted or forget about it, or could have just been that we were offering some equipment for them that they needed in the moment. But sometimes a shorter window to get responses back is more effective. So those are sort of the lessons learned, and some of the things we've been doing with telehealth, and very grateful to the partners in the consortium for helping us to do that. And I believe that's all I have to share. That's my information. If you guys have any questions or want connections to some of those, I'm happy to share it as well.
Thank you, Jenny. That was awesome. I really appreciate that lessons learned part as well. Does anyone have a question? Dawn, it looks like you might have raised your hand. Nope. All right. Anybody else have any questions that you might want to ask? Dawn says she's having some audio issues. Dawn, if you want to type your question in the chat box, we can get that for you. Of course, if Jenny obviously provided her email and her contact information. If you have a need for more information or want to reach out for more issue or more detailed information, feel free to reach out to her. That was really good stuff. I appreciate that. And we will move right on to Oregon and Washington. And so we are going to hear from Rebecca Dobert, who's the program manager at the Oregon Office of Rural Health, and Lindy Vincent, who's the Rural Hospital Program Manager at the Washington Office of Rural Health. And they are going to be discussing something that we've all heard of recently, and it keeps coming up, is the Antimicrobial Stewardship Program. I'm sure many of us have questions about that, or are interested in hearing more about that. So without further ado, Rebecca, you are up.
Hi, everyone. Hi, this is Rebecca. As Matt mentioned, the SHIP program coordinator for the Oregon Office of Rural Health. If you go to the next slide, yeah. I provided just a few little tidbits about the Oregon Office of Rural Health and our structure. I am part of the field services team, which provides data analysis and technical assistance to our small rural hospitals, including our critical access hospitals, and the SHIP program lives here. I like to point out a couple of things when I start an Oregon presentation about Oregon. In general, I like to note that we are a population of about 4.2 million people. And of that, 35% of our population is rural or frontier, and 10 of our 36 counties are frontier designated, and that is 6 or fewer folks per square mile. So sometimes our considerations are a little bit different for some of our eastern partners. If you go to the next slide. The Oregon SHIP program is also primarily administered as individual grants. Our most popular activities are HCAHPS and quality improvement activities, and we're really just beginning to see more interest in telehealth related projects. So I am the newbie here on this presentation with Lindy in Washington. You can see from the map here that our SHIP hospitals, we have 32 SHIP eligible hospitals in the state, 25 of whom are CAUSE, and they're in every region of the state. So we've got folks all over the place. So back to the SHIP program being administered as individual grants, we do offer a networked or consortium option every year. Usually we get about a third of the hospitals taking us up on it. So that brings us to the University of Washington Antimicrobial Stewardship Program, or the UW-TASP project, which we are helping shepherd some of our SHIP awardees into this year. So the UW-TASP project, the history in Oregon is that we actually initiated participation under the FLEX grant. Starting in fiscal year 18, we had 2 CAUSE participate, progressing in fiscal year 19 to 4 critical access hospitals, and then fiscal year 20, we have 5 CAUSE right now on partial year subscriptions. And so for the fiscal year 21 SHIP grant, based on the continued positive feedback from the participants and alignment with the FLEX offering, we've added support under the SHIP grant. And we have 4 hospitals this for the coming award who have elected to use part of their awards to support the work. Some of which are going to be returning hospitals and some of which will be participating for the first time. That original cohort under FLEX was also a multi-state group with hospitals participating from Washington, Idaho, and Oregon. And as such, UW was able to offer a nice group pricing structure for the combined group, so helping leverage the group or the consortium to maximize the accessibility via lowered pricing, and also making it affordable under the SHIP program as well. It will not use everyone's full SHIP allotment, so they can actually support some of their ongoing longer term projects, as well as joining into the UW-TASP cohort now. And some additional states are jumping on as well. Next slide. So what is the project? The UW-TASP project is run by the University of Washington Medicine. They provide infectious disease experts to work with the hospitals, and they help them either establish an antimicrobial stewardship program or evaluate and strengthen an existing program. The program provides didactic training and case discussions via weekly video conferencing, as well as one-to-one consultations. These were originally one-to-one site visits, which will be resumed as soon as they can. In the meantime, they do those consults via phone and video conference. The university offers our participants several program level options. There are a few different levels that they can get access to based on their subscription price. The first level is the most comprehensive. It includes access to the website, those weekly sessions, and those one-on-one consults and site visits. The second level is access to the website and the sessions, and the third level is just website access. Most of our participants are using the highest level, the website, the session, and the one-to-one consult options, and it's really highly valued. Participation in those weekly didactic video conferences is required, and they also include case discussions. All of the participants submit a minimum of 3 cases per annum for discussion, and that way everyone in the cohort has directly relevant cases that are discussed and worked on within the group. It's really a nice program. The curriculum keeps the teams from the hospitals up to date with federal regulations and anticipated regulation change that may be coming down the pipeline, and also their accrediting organization requirements. There are CE credits offered to physicians, nurses, and pharmacists participating in those teams from the cause. And it offers access to best practice procedures and protocols, and regular access to those UW infectious disease experts who are folks who have written the IDSA guidelines and have designed and built really successful programs of their own. If we can go to, oh, sorry, there's the rest of it. So you can see that participation requirements they are required to be active. This is not a phone in and sit quietly group. And there's a lot of interaction between the experts presenting and the teams from the hospitals. They do have to provide they have to be able to video and audio engage. Attendance is taken and reported to us so that we know that everybody is engaging. And then the task website offers tracking for projects. Can we go to the next slide, please? So this is a screenshot of one of the tools available on the website too from UW. They have several tools and resources available on the website via the access from the program. As I mentioned, the Oregon SHIP cohort participating in UW TASK will start just with the upcoming award, June 1st of 2021. So I'm going to turn over now to Washington State, whose participants are well underway.
Hi, everybody. As you can tell, the program is an excellent UW antimicrobial stewardship program. So I thought Rebecca and I talked, and I think I'll just round out. I don't have any slides. I'm just going to talk about how I actually got the hospitals to participate and a little bit of the hands-on piece. But I just, a couple of things that she talked about on UW. We do have 5 states in the West that are participating, and it's the 3 of us kind of got it going. It was Oregon, Idaho with Stephanie and Stacy and Natalia. We got Natalia is with UW antimicrobial stewardship program. She will, I'll just say task from now on, and she's the person to connect with. That information is in a informational document that I sent Andy to share later, and she will connect with anybody that wants to talk about it. But it is it's an excellent program because, and I'm just going to briefly talk about this before I go into how we did it, but the hospitals have to build a regional team, and the infectious disease, the pharmacy, the microbiology, the nursing departments, they all form a team and they're on the call. So at least 1 or 2 of those people attend almost every time. The other piece that is really important is that Natalia sends us an attendance record back, and we can see which hospitals are attending and which aren't, so that we're not wasting our money. And if somebody's not attending, then we can reach out to that hospital and talk to them, make sure that, this is still of interest to them. What are their challenges? A lot of times, with the pandemic, we had a lot of challenges this past year, but the attendance is really pretty steady. I've only had one or two. So in Washington State, just to give you a quick background, we have 39 critical access hospitals and 7 rural hospitals. So we have a total of 46 eligible hospitals for SHIP. And we started, for years, I've been wanting to, because I do both flex and SHIP, and I've wanted to meld the activities so that the great work we're doing is shared by everybody. And so I did a lot of brainstorming early on with our SHIP project officer on how this could be done. And then all of a sudden I had this opportunity of, it always seems like 1 or 2 hospitals kind of drop out at the end because of, a lot of times it's staffing. They just don't have the resources to complete or it was a corporate decision or whatever. And so I had a carryover one year. So I got it approved, and we decided to talk to the 7, at that time it was 5, we're up to 7 now, hospitals that weren't part of the Flex initiative for TASK. And they were very excited, and so we got to use our carryover money to get subscriptions. And the way UW works is it's called, and for those who all do state agencies, it's a subscription. So we either do a purchase order, PO, or we do a contract. Well, for our state, the indirects that come out of the bottom line on the budget for a contract is like 2 or 3% versus 25% when we do a purchase order. But purchase orders are often so much quicker. So what we found out, and this is something you may want to check if this affects I know it doesn't for Arizona because I've had this discussion with Arizona, but for some states that have the indirect issue and the how to do it, subscriptions and registrations for conferences, those are a lot lower indirect. So that's something you may want to just double check when you're trying to plan your budget around it. So I think it's 2.5% for a purchase order as long as it's a subscription. So we started about 4 or 5 years ago, and we did a survey to find out who was doing antimicrobial stewardship and with who. And we are now up to actually 32 critical access hospitals and 5 rural hospitals that are participating in the UW TASK program. And attendance has been steady. We do a survey every year to find out if it's still a benefit for them. They have these great toolkits, as Rebecca talked about, and they're from their policies, their procedures, and their protocols. And now they're starting to add new protocols for COVID, flu, all sorts of infectious disease. The protocol one I've heard a lot of really good things about. So that's how we now do POs for subscriptions, and we're starting to plan our 5th year budget and work plan around this. And we recently got 2 more hospitals on to SHIP. They got eligible for rural. So it's we're going to increase our numbers this year. And then once we get them going on that, then I start reaching out. It's time for the SHIP activities and the SHIP application. So I reach out to the hospitals that seem to, that are participating, and I talk to each of them what their telehealth needs are. And that's why I was like, that comment about group discounts. Oh, I really love that one. And that got me thinking, on another little line. So I do a lot of TA and one-on-one with them as I'm planning out the next year's work plan. And just to find out, and it's amazing some of their challenges, as some of the previous speakers have talked about. So I try to get them hooked into the correct people. And it also informs us you know, which way to go in other activities to support them through the telehealth. And then the last thing, because I'm looking at our time, and you were talking about the Northwest Telehealth Resource Center, and I have to tell you, we use them exclusively for another initiative that many of you have heard about. It's our palliative care initiative. And Pat Justice, who is our SOAR director, she leads it, and she's given presentations at different reverse site visits in DC, and has given a lot of presentations at conferences. So you may have heard her talk, and I think they're into their 3rd year. And it is an amazing program that the Northwest the Telehealth Resource Center does. You know, besides the one-on-one teaching that is done on how to use telehealth equipment that they do, we now have it set up so we have the hospital has a big camera. They do a case consultation, and I've sat in on many of them, and they're fascinating. And we have all the doctors and the nurses sitting around a table at the hospital, and then we have the physicians from UW, we have a physician from Providence that does palliative care, and we have a physician who she's a retired palliative care physician, and she lives in rural Washington. So, you know, you always worry about the bandwidth and how to make sure everybody stays connected during these, and they do an excellent job. I've never seen any technical difficulties, but they present the case, and then all of these experts give advice on it. And so it was pretty awesome to watch. So I think that's pretty much, I wanted just to kind of give you some ideas on how to make it work for your program, you know, not just the menu of activities that helps, but then actually paying for a year's worth of subscriptions. And they do give us a very competitive price. And Natalia can work that out.
Well, thank
I
you.
just want to point out that my colleague, Stacy Rothwell, who was our lead joining the cohort originally under Flex, she dropped the UW TASP website link in the chat box for anybody who's interested in finding out more. And I would also encourage you to speak with Natalia, who manages the program. It's a really great project.
That was really great stuff. Thank you, Linda and Rebecca. Of course, reach out to them if you have any questions in the chat box. There's a bunch of resources as well that have been posted. And as we mentioned, this is being recorded for playback. So if a lot of it was a lot of information, and it was, go back and listen to it again. Find those points that you might be able to hang on to for your own state program. Does anyone have any quick questions at this time that you would like to ask? Dawn, did you have a question that you want to ask? Is this now a good time to call back on you?
Yes, I have a question. Hello, everybody. Thank you
Hi.
all so much. All the presenters, it was excellent information. My question is for Iowa, I believe. The question was, do you offer the consortiums only, and or do you also allow them to do individual subgrants? And then I have one more question.
Yeah. So our goal, Kathy, I hope it's okay to answer this. Our goal is to transition the hospitals into the consortium if possible, and we do that by making it very, very attractive for them to participate. But we do have usually 9 or 10 out of the 80 hospitals that choose to still go direct award for each year. So a small percentage still do that, just if that's going to meet their needs better.
Okay.
But it is our goal to try and get them in the consortium.
Okay. Okay, thank you. And my second question is for you again. When you said that you offered, I think it was on the latter part of the year when you had the leftover money, and you offered some bundles, some telemedicine equipment, and also some other training or certification or something. Did you negotiate the prices for the telehealth equipment, or was there a partner that helped with that?
Yeah, so we worked with Global Partnership for Telehealth. They're a network that started out of a regional resource center, and they had existing relationships so that they were able to help us to negotiate on behalf of the hospitals for those services, and then reduced or no shipping costs and some of those things in the time of crisis. So it's Global Partnership for Telehealth is the group that we work with.
Okay, thank you all so much. I've been having a hard time trying to figure out how I can offer pooling or consortiums when it comes to telehealth. A lot of my hospitals really want the money to come directly to them. So thank you so much for these ideas. I appreciate it.
Yeah, and I'll also add too, and Jenny, feel free to jump in too if I say this incorrectly, but that is one of the benefits too that we pose to the hospitals as being part of our consortium, is that Jenny and Hometown Health does have really good relationships with different organizations. And so not just telehealth, but other areas too, they're able to have some group purchasing rates or some negotiated rates too.
That's awesome.
Awesome, thank you.
Yeah, great question, Dawn. Thanks for chiming back in and not giving up on that. I appreciate that. And so again, if you have questions directly for any of these people, feel free to reach out to them, or you can reach out to Sally, myself, or Andy with a question, and we will get you in contact with the right person. And so that kind of concludes our presentation parts of it. We do have a few announcements just to make at the end. Number one, you have a post-polling thing that just popped up on your screen. So make sure you run through that real quick before you jump out. We mentioned earlier that Soleil is going on detail assignment for 90 days. And Janine Myers will be the point of contact in her absence. We're excited for Soleil in that opportunity. If you have not done so yet, we do need your SHIP TA assessment by the 14th. So it's really a quick thing, just takes a few minutes. Matter of fact, right now would be a great time for you to do that. It is very important. We use that information constantly to make sure we're offering the best possible service to you guys. And then, of course, if you missed it, the SHIP grantee highlight in the RHI Hub's Rule Monitor article, highlighting the Oregon SHIP program in one of their hospital projects to improve quality and patient satisfaction through cultural competency training. The link is right there. Check that out. And then Soleil sent an email yesterday with a snapshot of upcoming reporting requirements under COVID SHIP and SHIP. And before Soleil leaves, she will update the calendar to reflect reporting requirements and templates where applicable for the fiscal year 21 and 22. The calendar will be emailed and posted on the SHIP website a few weeks before the new NOA are released. So make sure you see that email, and don't forget to email Janine to submit the minor alteration renovation activities reporting requirements for SHIP COVID. You can see the guide when the forms are available on the CARES Act SHIP funding page. So that's a lot of information there at the end. Again, this recorded, just be on top of those emails that we're sending out. Make sure you get that assessment done. And we really appreciate all of our presenters today. You guys did phenomenal. That was great information. Very useful. And especially for those of us that are looking to start something new in our own states, or be more cohesive in our own state. So without any further ado, that will wrap it up today. Andy, do you have anything to add?
I don't think so. I'll compile all the different resources that was shared and make that available. And like we said, within 5 business days, we'll get the recording up on the website as well. So thank you, everyone.
Yeah, thanks for being here, guys. We hope it was helpful and beneficial to you. And again, might have spurred more questions. Feel free to reach out to us or one of the presenters directly to answer your questions. Other than that, we hope you guys have a great rest of the week and an awesome weekend, and we will be in touch.
Thanks, everyone.